Welcome all and congratulations. The fact that you're sitting here today means you have chosen to take one of the most important professional steps of your life. You are about to begin the FCCCM Fellowship, a 2-year program that will transform you from a doctor who treats critically ill patients into a doctor who actually thinks like a critical care physician, who reasons systematically, who leads the teams under the pressure, and who can walk into any ICU in India, right from tertiary center to any hospital in rural India, and give your patients the best chance of survival. Now, over the next 1 hour, I want to do three things. First, I want to show you the philosophy behind this program because you cannot master a curriculum you do not understand. Second, I want to introduce you to a method of clinical reasoning that will serve you for the rest of your career. And we call it the Sherlock Holmes approach. And it actually comes from a real surgeon. We will talk about it. Third, I want to walk you through the entire year one structure, the modules, the assessments, the logbooks, so that on day one, you know exactly what is expected of you and you can plan your year. So let us begin. Now, before we open any syllabus, I want you to see this quotation. In 1892, Arthur Conan Doyle wrote to his old professor at the University of Edinburgh, Dr. Joseph Bell, a Scottish surgeon, and told him that Sherlock Holmes was based on him, not the other way around. Most people think Holmes is a fiction and medicine borrowed his method, but the truth is just the opposite. Dr. Joseph Bell, a real surgeon, born in 1837, had legendary diagnostic powers. He could look at a patient before they said a single word and deduce their occupation, their habits, their recent travels, and often their diagnosis from nothing more than just the observation. So he taught his students one thing above all else: observe carefully, deduce shrewdly, and confirm with the evidence. That is not detective work, that is actually the clinical medicine at its finest. And this is the method we will build the entire fellowship on. We call it the Sherlock Holmes approach, not because it is a fiction, but because it reminds us that the most powerful diagnostic tool in any ICU is not the CT scanner or MRIs or investigations or the ventilator. It is the clinician's trained eye and disciplined mind. Let me show you what I actually mean. 6 learning objectives, and I am going to be very precise about each one. First, I will teach you the Sherlock Holmes approach so that you understand our clinical reasoning method, not as a slogan, but as a real skill you will practice. Second, I will explain the training philosophy so you understand why we teach the way we do. Third, I will walk you through the entire year one structure, all 4 quarters, all 12 modules, and all 53 teaching sessions. Fourth, I will give you the assessment blueprint with exact weightage so there are no surprises. Fifth, I will read you the logbook minimums, the exact numbers of cases, procedures, ABGs, ECGs, and equipments write-ups you need to complete. And sixth, I will lay out the practical roadmap. That is, when the lectures will happen, what the 3 contact events are, and what your mentor expects of you. By the end, you will not need to ask anyone what is expected. You will already know everything about it. So let us start with the philosophy. Every training program has a set of assumptions buried underneath it. Most do not tell you what they are, but I am going to tell you explicitly because I believe a fellow who understands the why learns faster, complains less, and becomes a better doctor. So here's the program at a glance, and every number comes from the official FCCCM curriculum version 3.3, which is approved by CCEF Academic Council in April 2026. It's available on the website. 24 months, that's 2 years, competency based. Year 1 builds your foundation. Year 2 moves you towards independent practitioner. Now there are 3 compulsory face-to-face contacts throughout the year where you will meet your teachers in person. Assessment is continuous. It is not a single exam at the end. You will be tested every quarter by MCQs. You will sit an OSCE at the end of year 1, and then you will have a final exit examination at the end of year 2. We will talk about it in details later on. The exit competency is clear. We intend to produce a doctor who can walk into any general ICU in India, from a corporate tertiary center to a district hospital, and practice independently as a competent general intensivist. That is the target. Everything in the next 2 years is aimed at getting you there. So read these 10 objectives very carefully, because they are the contract between you and the program. Now notice that they are not all clinical. Yes, objective 1 through 5 are about managing patients and applying evidence, but objective 6 through 10 are about knowing your limits, communicating with the families, practicing ethically, teaching others, and understanding the Indian healthcare ecosystem. We are not here just training the technicians who can run ventilators. We are training the physicians who can lead teams, break bad news, allocate scarce resources, and teach the next generation. If you graduate from FCCCM, able to intubate beautifully but unable to explain a prognosis to a distraught family in Hindi or any other language, we have failed you. These 10 objectives will be assessed directly or indirectly throughout the 2 years. Keep them visible. Now let me explain why resource appropriate training is the first principle and not an afterthought. India's healthcare system is not one system. It is many systems operating in parallel. Now some of you work in tertiary centers with the latest equipments, while others work or will work in district hospitals where the ventilator is 10 years old and the nearest CT scanner is an ambulance ride away. The FCCCM curriculum does not pretend that everyone has the same resources. Instead, it teaches you to think. Clinical acumen over technology means that when you do not have a CT scan, you can localize a stroke with a neurological examination. When you do not have an ABG machine, you can infer the acid-base status from the clinical picture and the basic chemistry. The Sherlock Holmes approach, which we are about to unpack, is the method that makes this possible. And the cost-conscious decision making is not about being cheap. It is about being responsible, because in India, an unnecessary investigation can bankrupt a family. We here train you to order the right test, not every test. Now we come to the heart of how we think in this fellowship. The Sherlock Holmes approach is not a gimmick or a branding exercise. It is a structured method of clinical reasoning that traces directly back to a real surgeon. And it will be the lens through which you will approach every single patient in this program. Let me tell you the story of Dr. Joseph Bell, because it is one of the most delightful origin stories in all of medicine. Joseph Bell was born in Edinburgh in 1837 into a dynasty of surgeons. He trained at Edinburgh University, graduated before he was 21, and became a surgeon at the Royal Infirmary of Edinburgh. His diagnostics power were superb and legendary. Before a patient said a single word, he would study their hands, their gait, their skin, their clothing, and announce their occupation, their recent history, and often their diagnosis. He once looked at a new patient and said, "Well, my man, you have served in the army, not long discharged, a Highland regiment, and you were a non-commissioned officer stationed in Barbados." Everything was correct. But how? The man had a respectful but non-differential bearing, suggesting an NCO, a slight tan consistent with the tropics, and the specific gait of Highland regiment drill. Bell called this method the trained habit of observation. He would say to his students, the experienced physician, every day in the examination of the humblest patient, must go through a process of reasoning that requires senses to notice facts and education and intelligence to apply them. That is the Sherlock Holmes approach, and that is what we are going to drill into you. Here is the method distilled into 3 steps. Step 1 is observe, and I mean really observe, not glance at the monitor. Okay. So when you walk up to a bedside, look at patient's hands. Are they cyanosed, warm, cool, clubbed, etc.? Look at the respiratory pattern. Is he breathing labored, paradoxical, rapid, shallow? Is he on the ventilator? Is he on NIV, etc.? Look at the skin, the drains, the urine bag, the infusion pumps, anything which you look around. Read the monitor trend, not just the numbers on the screen at that particular moment. Look at the ventilator waveform, look at the bedside clutter, because messy bedside tells you something about the care also. So that is all about the observation. Then step 2, deduce or deduction. Take all these observations and ask, what do they mean together? For example, a warm periphery with a high heart rate and a low blood pressure. That is not just numbers, right? It is distributive shock until proven otherwise. So you form a hypothesis. Now challenge it. What else could this be? What does not fit into this? And so on. Then step 3, that is confirm. This is where you order the investigation. But remember, now it is going to be a targeted investigation driven based on your hypothesis and not just a scattergun panel, right? You are confirming or refuting a specific idea and then you act. The key word in Bell's rule at the bottom is apply. Remember, raw observation is useless without the clinical knowledge to interpret it. That is why this fellowship gives you both the structured knowledge in the lectures and the structured thinking in the method. Let me show you what this looks like at the bedside. Watch how the 3 steps play out. You walk into a bay or any new bedside patient. Nobody has handed you any notes, nobody has given you any history. You just simply observe. The patient is sitting bolt upright, leaning forward on nasal prongs at 4 liters of oxygen with SATs 91% on monitor. He's using accessory muscles. Breathing pattern is pursed lip. The chest is barrel shaped. The fingers are nicotine stained. On the bedside table sits a nebulizer and an inhaler. No IV antibiotics are running at present. You see, in 15 seconds of observation, before even you asked any single question or open the notes, you can deduce, that is step 2, that this is a chronic smoker with obstructive lung disease, probably a COPD in acute exacerbation. The pursed lip breathing is the giveaway. It is body's attempt to create intrinsic PEEP and keep the small airways open, right? The barrel chest says it's a chronic hyperinflation. Nicotine staining says etiology. The nebulizer says known disease. Absence of IV antibiotic tells you either the trigger is not infective or it has not yet been started or treated. Now you confirm with a targeted ABG looking for type 2 respiratory failure, a chest X-ray to exclude any consolidation or pneumothorax, and you act with controlled oxygen, bronchodilators, and NIV if the CO2 is rising. That is the Sherlock Holmes approach, and that is how I want you to think every time you walk up to a patient. Now, this method requires a foundation of knowledge, which is where the competency-based curriculum comes in. I want to plant this pearl deep because you will hear us saying this again and again over next 2 years. The most common reason a diagnosis is ever missed in the ICU is not a missing blood test or any missing imaging. It is a missing observation. Someone just did not look at the patient. They looked at the monitor, looked at the numbers on the screen, but they did not look at the breathing pattern, the skin color, the drains, the infusion rates, nurse's face, and so on. So train your eyes before you order your bloods. If Joseph Bell could diagnose a patient's occupation, recent travels, and disease from across the room in 1880, you can certainly pick up a tension pneumothorax or a septic patient from the end of the bed in 2026, correct? That is what we will train you to do. Now let us look at the competency-based model. Let me be explicit about what competency-based training means, because it is different from the way most of you were trained in medical school. Now, in a traditional program, you pass by surviving the time. So actually you spend an year, you sit an exam, you pass or you fail. But in competency-based program, the question is not how long did you spend. It is what can you now do. Your logbook is not a formality. It is the evidence that you can intubate, insert a central line, set up a ventilator. You can actually lead a resuscitation. Your quaternary exams are not hoops to jump through. They are checkpoints that tell us and tell you whether you are on right track or no. Your mentor is not a distant figure who signs your form at the end. They are a named teacher who watches your clinical performance, gives you feedback, assesses your professionalism and work ethic. And the exit competency is very specifically defined. Independent general intensivist practice. Not a subspecialist, not a researcher, not a theoretician, but a doctor who can walk into a general ICU and run it competently, safely, and independently. Now we open the map. Year 1 is actually your foundation year. 12 months, 4 quarters, 12 modules and 53 scheduled teaching sessions, including online lectures, landmark trial reviews and workshops. Let me walk you through each quarter so you can see how the year is designed to build progressively from the airway to the exit. Now this is a very important slide. Here is the year laid out as a 4-color map. Quarter 1 is in blue, is months 1 to 3, includes fundamentals and resuscitations, and modules are 1 to 3 again. This is your ABC, basic airway, breathing, circulation, shock recognition, fluid therapy, vasopressors and ACLS. We start with this because if we cannot secure an airway and resuscitate a patient, nothing else matters. Then in quarter 2, which is in purple, it is months 4 to 6, which includes organ systems and monitoring. We are going to cover in here neurology, renal, GI, nutrition, acid base through modules 4 through 6. Now here you are building your organ system knowledge. Then comes quarter 3, which is in amber. It is months 7 to 9, where you're going to cover infection and inflammation. The modules will be 7 and 8, which include sepsis, tropical infections, hospital-acquired infections, antimicrobial stewardship, and hematology. Now, this is where India's specific disease burden comes in, such as malaria, dengue, scrub typhus, leptospirosis, tuberculosis, etc. Then in quarter 4, which is in steel gray, that is from month 10 to 12, we are going to cover special situations. Toxicology, including OP, poisoning, snake bite, etc. Then trauma, obstetric critical care, and of course, ethics and communication. Notice the design. Each quarter ends with a centrally administered MCQ examination. You will be tested every 3 months. This is not optional. Okay. Now let me zoom in into each quarter. So this slide details about first quarter, that is fundamentals and resuscitations. I will not read every line because it is all on the slide and in your curriculum document, but notice the progression here. Each module builds on the previous one. The lectures are not just random topics thrown together. They will follow a clinical logic. And each quarter ends with a landmark trial review because we want you thinking about evidence from day one, not just memorizing protocols. The by the end of line at the bottom is your personal checkpoint. If you reach the end of the quarter and you cannot do what that line says, in that case, you really need to speak to your mentor immediately. Now this slide shows details about second quarter, that is about organ systems and monitoring. Again, I will not read every line because it's there on the slides and your curriculum. But here also you notice the progression. Like the previous one, each module builds on the previous one. The lectures again are not random. Each quarter ends again with a landmark trial review because we want you thinking about the evidence right from the beginning. The last point, by end of that line at the bottom, is your personal checkpoint as your quarter 1. The same goes with quarter 3, which is about infection and inflammation. Again, landmark trials and the progress is the same. And the same goes with the fourth quarter, which is about special situations, right? So I hope you have understood the exact pattern of each quarter. Stop. Think about this before we continue. Say it is your month 5 of fellowship. You are on night duty. A patient arrives unconscious, GCS is 6, pinpoint pupils, respiratory rate is 6. There is a chemical smell on his breath. There is no history, no family, no toxicology screen. What do you need? The answer is that you need module 1 right now because the respiratory rate is 6 means this man is about to stop breathing and you must secure the airway immediately. You also need module 9, which is toxicology, which is not until quarter 4, but the clinical picture suggests the poisoning, likely organophosphorus or opioid, and you need to think about antidotes. And the first step of the Sherlock Holmes approach method is observe. Pinpoint pupils plus low respiratory rate plus chemical smell, which actually equals to a cholinergic toxidrome or opioid overdose. The observation drives the deduction. The point of this whole exercise is to show you that the curriculum is not sequential in actual life or the real life. Patients don't read your modules and come accordingly. They can test any module anytime. That is why we build the foundation first and then everything else connects. Now let us look at how we assess you. I'm going to show you the exact assessment structure, the exact weightages, and the exact logbook minimums. Our philosophy is very simple. If we tell you exactly what is expected on day one, you have no excuse for not meeting it. There will be no surprises. Here is the assessment structure, and I want you to photograph this slide. Very, very important. You can take the pictures. There are four components, right? First, internal assessment, which carries 5%. Now, this is your teacher's evaluation of your clinical performance, professionalism, and work ethics throughout the year. Then the logbook carries 15%, includes your SLA certificate. Then written examination is 40%, and listen, this is very, very important. The written mark is the aggregate of your quarterly MCQ scores. That means every single quarterly exam counts. You cannot just skip one quarter thinking you will make it up in the next one or any other one. And OSCE is 40%, which has 8 stations, which is conducted mostly online in year 1, but it can be offline. We'll talk about it later on. The pass mark for each component is 50%, and you need to have 50% overall score. Notice the weightage. The OSCE and the written exam together will account for 80% of your marks. That is actually deliberate. We are assessing what you know and what you can do, not just whether you turned up. Okay. So there are 8 OSCE stations, and every station will test a practical bedside applicable skill. You notice there is no station called write an essay or recite a textbook. Every station asks you to interpret something which is very, very real, like an ABG, a biochemistry panel, an ECG, X-ray, CT, a ventilator waveform, a coagulation profile, or a drug or a piece of equipment. Now, these are the things you do every day in the ICU, right? If you have been doing your logbook properly, you have been working properly, you're logging your ABGs and ECGs and imaging, you will walk into these stations with confidence because you have already practiced and you've been doing it day to day. But if you have not, you will struggle. That is why the logbook and the OSCEs are actually two sides of the same coin. Now let me show you the logbook requirements. Now here are the exact logbook minimums for year 1, taken directly from the curriculum document. Now I want you to either take a screenshot, take a photograph, or write these numbers down. Very, very important. You need to have 5 detailed clinical case workups with proper clinical reasoning, not just a discharge summary, but a structured workup showing your thinking process. 10 ABGs with systematic interpretation, 10 biochemistry panels, 10 ECGs, 10 X-rays, 5 CT scans, 5 drugs write-ups, 5 equipment write-ups, 5 hematocoagulation profiles, and 5 graphs or waveforms. Remember, these are minimums. They are not the targets. A good fellow will exceed them comfortably. But if you do not reach these minimums also, your logbook will not pass. And remember, it is worth 15% of your final marks. My practical advice, start from week 1. Do not wait until month 10 and try to cram 10 ABGs into the logbooks. No, the best thing would be take 1 ABG a month, properly interpret with clinical contents, and that's so easy and it builds the habit. Now again, very important aspect, that is the procedural number, and these are absolutely non-negotiable. 15 intubations, 15 central lines, 10 arterial lines, 15 ventilator setups, 15 NIV setups, 2 chest tubes, 5 CPR leadership episodes. Lumbar puncture, thoracocentesis, paracentesis, these are listed as optional, but I encourage you to seek those opportunities. Now notice the competency level column. It says supervised progressing to independent. That means your first intubations will be done with a supervisor beside you. As you gain the skill, your supervisor will step back, and by the end of the year, you should be performing these procedures independently with the supervisor available but not scrubbed in. Document every procedure in your logbook with the date, supervisor's name, and the outcome. A logbook entry which just says intubation, date, done, etc. is not acceptable. We want to see the clinical context, the difficulty, and what you actually learned. So, what's gonna be your practical roadmap? Now that you know what you will learn and how you will be assessed, let me tell you how the learning is actually delivered day to day and week to week. Now let's see how the learning is delivered. There are 5 delivery channels and all 5 matter. First, weekly online lectures. Now these are structured teaching sessions covering every module in the curriculum. And I need to be clear that attendance of at least 75% is mandatory. If you fall below 75% attendance, remember you are not eligible to sit the examination. Second, your ICU bedside training. You must be working in an ICU for the full 24 months of this course. The ICU is actually your real classroom. Online lectures are just the theory that makes your bedside learning more effective. Third, 3 compulsory physical contact events. Now, these are face-to-face sessions with the college teachers. These will be typically 3 to 4 days each. Year 1 orientation, Year 2 orientation, and a crash course before the practical exams. They require separate registration and separate fees. Do not skip this. Fourth, your named mentor. This is a senior intensivist, often your ICU consultant, who will monitor your progress, review your logbook entries, assess your clinical performance, and give you feedback. Build a relationship with your mentor from week 1. Fifth, the CCEF Knowledge Hub, our superb online platform to which you will have access for 24 months as a part of your course fee. So let's talk about compulsory contact events. There are 3 contact events, all are compulsory, all face to face with the college teachers. The first is your year 1 orientation. Right now what we are having is a Zoom orientation, but you're going to have a physical 3 to 4 days orientation very soon, where the foundation topics will be discussed and taught to you. You will meet your teachers and we'll set the expectations from there. The second is the year 2 orientation, which will be on advanced topics. Again, same 3 to 4 days topics. The third is going to be your crash course before the final exit examination. There will be an intensive revision and mock exam, especially on OSCEs. So it gives you a better idea about how to crack your exams and how is going to be final practical exam in short. Remember, each one is going to cost you approximately 20,000 rupees payable separately, and travel and accommodations are going to be your own responsibility. I know that is an expense, but these events are where you will meet your examiners face to face, you will learn lots of things, practice clinical skills under supervision, and calibrate your performance against your peers. They are not optional. Now, after FCCCM, what does this lead to? You will have 4 career pathways. First, direct practice as a consultant intensivist anywhere in India, from a corporate tertiary center to a district hospital. Second, academic medicine. You can teach, you can become a clinical instructor, you can join a continuing medical education facility, and you are eligible to become a teacher as soon as you pass out your FCCCM exam. Third, if you want to subspecialize, the AFIC Advanced Fellowship in Intensive Care program offers 1 year subspecialty in neurocritical care and cardiac critical care with more subspecialties to follow. And the fourth one, administrative roles. You can become an ICU director, quality improvement lead, healthcare administration, etc. So the FCCCM opens all of these doors as soon as you pass out. Before I summarize, let me show you something that makes this program totally different from any other critical care fellowship in India. We have built a complete digital ecosystem around you. 5 platforms and tools, each one designed for a specific purpose, free or included in your course fee. Let me walk you through them one by one, because the fellows who use these resources consistently score higher, finish their logbooks faster, and feel more prepared for the exam and actual life also. The first one is icueducation.com. It is the self-assessment and online training portal. Think of it as your personal exam simulator. It has a huge database of self-assessment questions across all the critical care topics, and you can practice them privately at home or in the office without anyone seeing your score. That matters because the best way to learn is to test yourself and discover your weak areas before the exam actually discovers them for you, right? It also hosts various formal online courses and premium courses with certification, a media center with presentations and downloadable documents, clinical cases for discussions, and certificate validation so your credentials can be verified by any employer. Most importantly for you right now, it is where the free weekly online classes are announced and tracked. Your attendance at these classes needs to reach 75% for exam. Remember that for your eligibility. So register on isueducation.com with the same email ID you use for FCCCM enrollment and check it every week. Okay. Next is the CCF Knowledge Hub. This is one of the best thing which has ever happened, and you are the lucky ones to get this. There is knowledge about every topic in critical care. Along with that, it is your MCQ practice platform. It is included in your course fee for the next 24 months. It's almost a value of 60,000 rupees, 30,000 per year. This is not a collection of random questions. It is a structured subject-wise question bank where you choose a topic, you sit a time test under exam conditions and get detailed explanation for every answer, right or wrong. The explanations are the learning. When you get a question wrong, the explanations teaches you why, and that single moment of correction is worth 10 pages of passive reading. It has a progress dashboard so you can see your scores every time, identify which subjects are weak and focus your study accordingly. There is a student community for discussion, mock exams in the actual exam format, webinars and documents. My advice, do at least one knowledge hub quiz per week from week 1. By the time you reach your quarterly MCQ exams, you will have seen hundreds of questions and the format will feel familiar and not frightening. The next is collegeofcriticalcare.org. This is the official portal of the College of Critical Care Medicine. This is where the curriculum document you have just heard you will find, along with all examination guidelines, application forms, and logbook templates. The program section has full details on FCCCM, EFIC, and IFICM. The document section is your reference library for official college materials. Weekly lectures section shows the upcoming schedule. The fellows directory lists every FCCCM and EFIC fellow, which is your professional network and will matter when you look for the positions after your graduation. Bookmark this site, okay? Check it regularly. When in doubt about any program rule, the answer is here. Next one is CCF Logbook Generator. This is a tool we are extremely proud of and it will save your hours. The CCEF Logbook Generator is a browser-based application with 17 ready-made templates covering every single logbook category in your curriculum. When you need to log an ABG, you open the ABG template, enter patient's values, and the app will automatically calculate acid-base status. It will flag abnormal values, generate a beautifully formatted PDF or a Word document that is ready to go straight into your logbook. The same will apply for you. ECGs, X-rays, CTs, drug profiles, equipment write-ups, hemodynamics, ventilator waveforms, and even antibiograms. The key feature shown at the bottom is privacy. Everything stays in your browser on your device. Nothing is sent to CCF until you choose to download and submit your files to the CCF. So you can practice, make mistakes, redo your entries. Nobody sees them until you are happy with the final version. Start using this from very first week. Every time you see an interesting ABG or ECG in the ICU or any data, just pull up the generator on your phone, enter the data, and you have a logbook entry done in 5 minutes. Do that consistently and your logbook will be complete months before the deadline. I think we are going to have a total separate session on how to use CCF Knowledge Hub, your CCF logbook generator, and isueducation.com. Next one is very, very important, medical statistics case generator. Now, medical statistics is the topic that terrifies most fellows, and that is precisely why we built this tool. You don't bother about it right now because this is going to be your year 2 OSCE station, and a detailed lectures, beautiful simplified lectures by Dr. Jain will be there in the year 2. Now, this medical statistics case generator gives you 5 randomized clinical statistics scenarios, each drawn from a pool of 10 questions per category. So you get a different set every time you use it. There are 4 mandatory or compulsory categories that every fellow must complete, which will include critical appraisal of an ICU trial, number needed to treat, number needed to harm, sensitivity and specificity, and probability and confidence interval. Then there are 6 elective categories for deeper practice, which include descriptive statistics, measures of spread, hypothesis testing and p-values, risk measures, sample size and power, correlation and regression. Now, for each scenario, you read the clinical vignette, type your working and your final answer, and the tool exports the formatted logbook entry directly. If a randomly drawn question feels very unfamiliar to you, you can reshuffle up to twice, 2 times for that particular scenario to get a different one from the same category. But the difficulty level will not change. It will remain the same. You use this tool to build your statistics logbook entries and to get comfortable with the kinds of questions you will face in the year 2 OSCE. Statistics is not hard if you practice. It is only hard if you avoid it. But at this moment, this is just an introduction. Remember, you are going to learn a lot in detail as you enter your year 2. So here are all 5 resources in one table. Bookmark them all today. icueducation.com for self-assessment and weekly classes, ccfknowledgehub.com for structured learning on various topics, followed by structured MCQ practice and progress tracking, collegeofcriticalcare.org for official documents and applications, the logbook generator for turning your daily clinical encounters into formatted logbook entries in minutes, and the medical statistics case generator for building your statistics logbook and conquering the one topic that frightens most fellows. Remember, these tools were built specifically for you. They are not generic resources borrowed from somewhere else. They are designed around the FCCCM curriculum, the FCCCM logbook requirements, and the FCCCM exam format. Fellows who use them consistently from week 1 finish their logbooks months earlier, score higher on quarterly MCQs, and walk into their exams feeling prepared, not panicked. The tools exist. The question is whether you will use them. 6 things you will carry from today. Number 1, Sherlock Holmes approach, which is observe, deduce, and confirm. Your most powerful diagnostic tool will always be your trained eye and disciplined mind, not the CT scanners. Number 2, this is competency-based training. You will advance by demonstrating what you can do and not by just surviving months on a calendar. Number 3, remember year 1 has 4 quarters and 12 modules. Each quarter ends with an MCQ exam that counts towards your final marks. Number 4, assessment is continuous and absolutely transparent. You will have 5% for internal assessment, 15% for logbook, 40% for written exam, and 40% for OSCE. The 5th, very important, start your logbook from week 1. Remember, the minimums are real, the numbers are very specific, and leaving them to the last quarter is actually a recipe for failure. Last but not the least, your mentor is your ally. Build that relationship early. Show them your logbook. Ask them for their feedback. Do not be the fellow who submits the logbook for the first time on the day of the exam. Right? So with that, I welcome all of you to the FCCCM program. The next 2 years will be the hardest, but trust me, they'll be the most rewarding of your career. So let us get to work.